So can we start the session right now?
Okay, so hi, very good morning, everyone. Welcome to our CMAAO International Weekly Session. We are live on 24th of February. It's an Indian Standard Time, 9:30 a.m. It's a very common and a very important topic we are discussing. So if anybody wants to open this session and come and join, they can join on Zoom at 818-859-11572. I repeat, 818-859-11572. And please leave your questions and we will ask the expert. So today we have as an expert, Dr. D.K. Sinha. He's a DM and MD Nephrology, Senior Consultant at the Department of Nephrology at Heritage Hospital, Varanasi, Uttar Pradesh. Dr. Sinha is a member board of directors and a head of department for nephrology Galaxy Hotel in Varanasi since 2009. He's a medical director at Heritage Renal Edge, which is running currently 26 dialysis center across Uttar Pradesh on a PPP model. He's also a principal investigator for multinational and international multi-center trial. He was invited faculty in various national and international conferences and delivered many lectures across countries and overseas. So we are blessed to have you here for your guidance. Please start your presentation. Thank you.
Thank you. Thank you, Saurabh, and good morning to everyone who are participating in this meeting. It's my pleasure to be part of this very prestigious meeting. And basically, I'm working in city of Varanasi, supposed to be holy city, and are blessed with the Lord Vishwanath. So today's topic is really very important topic, as well introduced by our Mr. Saurabh. The topic is really relevant. Why it is so? Because a large chunk of population is having some or other form of CKD. So somewhere around 10 to 16% of population, they are having incidence of CKD. So am I allowed to share my screen?
Absolutely, sir. Go ahead.
Thank you. So fine. So is it visible right now?
Perfect.
Thank you. Thank you. So what I'm going to talk today is basically a nutshell or overall view of the chronic kidney disease and how we can manage the chronic kidney disease in our patients. The topics, if you see the contents of today's discussion is the introduction, prevalence, definition of CKD, causes of CKD, progression of CKD, management of the progression of CKD. In that, we are going to discuss the different causes of CKD, including diabetes, hypertension, anemia, BMD, salt, protein intake. The newer therapy which have come in the practice in recent past, like SGLT2 inhibitor, a little bit about finerenone, GLP-1 receptor agonist, and when the patient should be referred to a nephrologist, or when a physician should aware that when the patient should be treated by a nephrologist, not by a physician himself or herself, and when to initiate the renal replacement therapy. Now, coming to the global prevalence of chronic kidney disease. As the population grows older, the incidence of CKD also increases. Like for the age of 65 to 74, around 20% of the men are having CKD, and around 25% of the female are having CKD. In the older age, like more than 75 years or so, around 40% of the population of male and around 60% of female may have CKD. Overall, around 1 in 7, so around 14% of US population adults are estimated to have chronic kidney disease, and it's a huge number. Even we have also conducted our own study, and that was called a SEEK study in India, They have also shown the incidence of CKD in Indian population is somewhere around 14 to 16%. So we can imagine the magnitude of CKD in the population. So why those number of patients are not being evident in the population, though they are having CKD? Because most of the patients of CKD are in the stage 1, 2, or 3. How are being classified CKD? We will discuss later on. Now, coming to the definition of CKD, CKD is basically if you are going to get the abnormality in the kidney structure or function, which is present more than 3 months. And what are the markers of CKD or damage? Either patient is having albuminuria, abnormal urinary sediment, electrolyte abnormalities, or histological abnormalities, structural abnormalities, or some histology of kidney transplant event. Or if the patient is having persistent fall in eGFR less than 60, then it is being called as CKD. Now, coming to the stage of the CKD, that's very important because this is being classified in basically 5 stages, and stage 3 is being classified in A and B. And there is one very important aspect why this is being classified in A and B. So if the eGFR is more than 90 or so, it is called mild kidney damage because here the kidneys are working almost normal. In a stage 2, it is between 60 to 89, and it is also mild kidney damage, but still here kidneys are working well. 3A is 45 to 59, 3B to 30 to 44, stage 4 is 15 to 29, and stage 5 is less than 15. So what is being seen in the population that the patient who are having stage 3A and 3B, the incidence of cardiovascular disease is very high. And because this is not very evident in the clinical practice or even in the investigation, the reports are very close to very normal. So people or even physicians usually ignore this stage of CKD. But the incidence of cardiovascular disease is very high in this population. And that's the reason this is being classified in stage A and B to give more focus on this stage. Another very important aspect in classification of the CKD is the extent of albuminuria. And this is being categorized in 3, A1, A2, and A3. So when the urinary albumin creatinine ratio is less than 30 milligram per gram, it is being called A1. When it is between 30 to 300 milligram per gram, it is A2. And when it is more than 300 milligram per gram of the creatinine, it is called A3 or severely increased value of albuminuria. I think these two parameters, the eGFR and the albuminuria, these two aspects are very important in classification of CKD and in prognosis of CKD as well. So like if you see, this is a very, very important slide for all of us because based on these eGFR, that is G1, G2, 3A, B, 4, and 5, and proteinuria A1, A2, A3, we can quantify the future aspect of any CKD patients. Though this is not absolutely accurate, but at least in clinical practice, we can judge that this patient is having a risk, how much risk in progression in the future. So what we can see that there is one zone which is called green zone, another is yellow zone, then orange zone, and then the red zone. So patients who are in the green zone, they are having the least chance to progression of CKD. In yellow zone, definitely this is yellow alert for each and everyone. Orange is definitely a little bit higher, but the red zone is definitely a very high risk zone because these subset of patients are very prone to progress over the period to the ESRD or so. But at the same time, we have to keep in our mind, but a very small percentage of patients are basically reached the stage of ESRD. So what usually happens in rest of the patients? So other complications in these subset of patients are always very high, like cardiovascular disease, cerebrovascular disease, incidence of infection. And these complications are really a very serious complication. And most of the patients of CKD basically do not reach at the stage of ESRD. Rather, they die prior to reaching to that stage. So that's very important. We have to quantify the classification, and at the same time, we have to explain each and everything to the patients. So now coming, how we can have a clue of diagnosis of CKD from a patient history. So a few things are really very important, that we have to review the system, any recent infection, skin rash, or any parentally transmitted disease. Another group is chronic disease like diabetes and hypertension. These are very, very important because the incidence of CKD is very high, and they are main disease which is contributing most in the CKD group. Any past medical history or history of intake of NSAID, or any history of hypertension or proteinuria in the childhood, any difficulty during the pregnancy in the mother. Past urological history is also very important. Familial history of the kidney disease in the family is also very important. So we have to ask to the patients about the family history also when the patient is coming to our clinic. Every generation and predominantly male are more susceptible in some type of CKD like Alport's disease or something like that. So these are the few clinical clue we can get from the patient. Now coming to the classification of CKD based on the presence or absence of systemic disease or location within the kidney of the pathological hello, am I audible?
Yes, sir, we can hear you.
Oh, yes, sorry. So if where these pathological changes are happening, like if you see the glomerular changes, that usually happens in the diabetes, systemic autoimmune disease, systemic infection, drugs, and neoplasia. So here what we can get in our patient, that patient's glomeruli will have changes like diffuse changes, focal changes, crescentic proliferation. Many diseases are predominantly involving the tubulointerstitial disease, like some infection, autoimmune sarcoidosis, drug, urate, like the UTI, stones, and obstruction usually involve the tubulointerstitial disease. Some of the disease are basically vascular disease in the kidney, like ANCA-associated vasculitis, fibromuscular dysplasia, or something like that. Cystic and congenital disease is another group of CKD kidney involvement, and which we can see in the renal dysplasia, medullary cystic disease, and podocytopathies. Now, coming to overall causes of CKD, what I told you earlier, that diabetes and hypertension, if you see this pie diagram, we can see here the majority of patients who are having CKD are basically patients of diabetes and hypertension. So around 67% of total CKD patients are basically having diabetes and hypertension. Other are glomerulonephritis, interstitial nephritis, and 18% are a different other group disease, which I just told you that. So looking on this chart, we can say that we have to very much cautious in treating the patients who are having diabetes and hypertension, because these are the patients who are going to develop CKD over the period. And here we have to give more attention in managing the hypertension and diabetes. Now coming to the predictor of the progression of CKD. So we have to identify the predictors in the patients, which is a very basically indicator that this particular patient is having a chance to progression of CKD in the future. So as I told you earlier also, the level of GFR is very important, because the lower the GFR, the higher of chance of the progression. Because if you recall that slide in which I have given the green yellow, orange, and red, then the lower EGFR, like red zone, they are more prone to have progression in the future. Level of albuminuria is another factor. Age, sex is also very important. Race like the African American and African race is more prone to uh, progression of disease. Higher blood pressure, hyperglycemia, dyslipidemia, smokers, obese patient, history of cardiovascular disease, and ongoing exposure to nephrotoxic drugs. These are the very important factors which basically increase the progression of CKD over the time. So what is the significance of intervention in the CKD patients? That we have to understand, because if you see the black line, if you are not treating the patients, what's going to happen that over the period, patient is going to develop the severe renal failure or end-stage renal failure. So this is the usual track of the patient, the first line. But if you are going to intervene in the patient's management at the early stage of the disease, then patient may have a longer duration of dialysis-free life. And if you are going to even intervene a little bit late also, even then you can give a good, fruitful, dialysis-free life to your patients. So what is the meaning of this slide? That basically early intervention is very important even in all CKD patients, because you can change the overall track of the disease in the future. Now coming to the whole focus of the management of CKD is basically how we can approach to preserve the kidney function over the period. And what is being done in the management of CKD is basically a symptom management. Another is palliative care and kidney preserving care. So for kidney preserving care, what we usually do, we basically advise diet and lifestyle. For disease progression, we give RAS inhibitor, SGLT2 inhibitor, MR antagonist, disease-specific drugs are basically being used. For cardiovascular risk management, BP lowering is very important, glucose lowering is very important, lipid lowering is very important. Diuretic is being used to manage the volume status. And for other comorbidities like acid management, potassium binders are being used, anemia management, and bone health management. So if you see the overall slide, this is basically part of supportive care and conventional care. And basically, patient needs a very comprehensive care if you really want to retard the progression of CKD over the period. And these are the histological sites in the kidneys where all our the measures are being used, are being going to be effective. So we always try to improve the tubular structure and integrity and the function. We want to reduce the intraglomerular pressure by giving different drugs and diet modification. We try to decrease the inflammation and the interstitial fibrosis. So for that, we need a lifestyle modification. We need a good control of blood pressure. We need the good control of diabetes. We have wide enough for toxic drug, and different modalities are being used at the same time to get all this beneficial effect. Now coming to the different measures, what is being done in the CKD patients, like the protein intake. And this is very hotly discussed topic, how much protein we should give to our CKD patients. So what is important that usually in patients of CKD, a low protein diet is being recommended. And the usual diet for the adult is 0.8 gram per kg per day. But one should avoid to giving a very high protein diet, because the high protein diet is having a relationship with the hyperfiltration of the in the kidney, and which is going to have a deleterious effect in overall progression of the CKD. Another very important aspect is the salt intake. Usually this is being advised that the patients of CKD should receive a salt less than 5 gram or so. So salt restriction is very important because it's also having a very close relationship with the overall blood pressure of the patients. And a good blood pressure control is definitely going to give a good beneficial effect in the terms of retardation of the progression. Another is lifestyle modifications. Physical activity is very important. At least 30 minutes uh, physical activity or exercise at least 5 times per week is being recommended in most of the patients. And this and then uh, individual with the CKD should receive expert dietary advice in the form of decrease in the overall phosphate intake, decrease in the potassium intake, and of course the proper intake of the protein in the future. The plant protein and the animal protein should be balanced well because around 50% of proteins should be come from the animal origin. So class 1 protein should be 50% and 50% should come from the plant protein. Physical activity, as I told you earlier, also weight reduction is also very important because overweight patients are having a very hyperfiltration in the kidneys, and it's going to further worsen the progression of the disease. So that's why weight reduction, and one should try to cut down the weight and try to get the BMI close to the required rate if it is possible. Smoking cessation is also very important because smoking is one which always increase the risk of all cause mortality, including the vascular causes and cancer in the people of CKD. And at the same time, this is one of the very important vasoconstrictor. So once the patient develops vasoconstriction, there is poor supply of the blood to the kidneys. There is chance of hypertension in those subset of patients. So smoking should be stopped altogether in each and every CKD patients. Now coming to the different disease aspects one by one. So one is management of diabetes. What I told you that diabetes is most common cause of CKD. So each and every patient of diabetes should be screened for CKD. So for type 1 patients, it should should be starting after 5 years of the diagnosis. For type 2 diabetic patients, each and every patient should be investigated for CKD at the time of diagnosis. And if the test report is positive, there should be repetition of the test for the confirmation of proteinuria and EGFR. If there is some doubt, cystatin C can be used for the same purpose. And we should start evidence-based treatment. For this screening, spot urinary albumin creatinine ratio is supposed to be very good, and EGFR calculation from the serum creatinine. So as I told you, the CKD means there is persistent proteinuria and they fall in EGFR or other evidence of CKD. What is the goal in the management of diabetes is basically HbA1c should be 7 or less. If it is less than 7, then there should be no very aggressive therapy of the diabetes, because then the chance additional benefit is less in those subset of patients. And but at the time of management of diabetes, we have to see a comorbid condition and the longevity of the patients at the same time. So few drugs are really very important, which are being used to retard the progression of CKD in diabetic population, like SGLT2 inhibitor, which is recently introduced in our clinical practice and is supposed to be very important also. So how this SGLT2 inhibitor work? This is basically decrease the plasma glucose, decrease the body weight, decrease the blood pressure, decrease plasma uric level, and also decrease the glomerular hyperfiltration. So basically, there is vasoconstriction of arterioles, and there is more delivery of sodium and chloride to the macula densa. So there is basically positive feedback mechanism happening in the kidney, and that's why it's leading to decreased hyperfiltration. And it's not only so, that's other pleiotropic effect that's going to be happen in the kidneys also. This SGLT2 inhibitor is basically inhibitor of sodium hydrogen exchanger, and these exchanger are available in kidney as well as in the heart also. So in heart failure and the kidney problem, what happens? There is sodium retention and there is also increase in the cardiac wall stress. So if you are going to use this drug in our patients, so there is inhibition of NH3 in the kidney and NH1 in the heart. So there is overall reduction of the major adverse heart failure outcome, and there is also blood pressure lowering and the nitrouresis in the kidney. And what are the evidence of beneficial effect of SGLT2 inhibitor in the clinical practice? There are a few landmark studies which have shown that this drug is very useful in diabetic patients, like Credence study in which canagliflozin was studied in the renal outcome in type 2 diabetic patient, and we can see that there is around 30% reduction of primary outcome and 22% reduction in the end-stage renal disease. At the same time, there was no increase in the amputation or the fracture incidence. Another very important landmark study is DAPA CKD study. We can see in this study, it was a multicentric and multinational study, and which have shown that when patients are being used with the dapagliflozin 10 milligram, there was a reduction of 29%, or we can say the hazard ratio was 0.61 for fall in GFR, for ESKD, for renal CV death, around 0.56 for all the ESR, CKD, and renal death. Cardiovascular death was also, the hazard ratio was 0.71, and all-cause mortality was 0.69. So we can see here there was a significant fall in overall incidence of all these complications in the DAPA group. Similarly, we can see even in the patients of IgA nephropathy also, which is supposed to be the most common cause of glomerulonephritis all across the world, the use of dapagliflozin has shown a very positive outcome in patients being treated with this drug. Another SGLT2 inhibitor is empagliflozin, and this is EMPAS kidney trial, in which they have shown that the incidence of different complications across these patients, like CKD progression in death from CV versus 31%, 31.1% in IMPA versus 16.9 in placebo group. Hospitalization from any cause 24 versus 29. Hospitalization for heart failure or death from CV caused 4% by 4.6, and death from any cause 4.5 to 5.1. So they have shown that there was significant reduction in different complications in diabetic population. Another anti-diabetic drugs, that is GLP-1 agonist, that has also shown a beneficial effect, like the semaglutide. They have shown that there was HbA1c reduction, weight loss, blood pressure law control, and decrease in urine albumin creatinine ratio. So what are the top 10 takeaway when we are going to manage the diabetic patients? And KDIGO 2022, they have given their comprehensive management advice that it should be a comprehensive care. Nutritional intake is very important in these subset of patients. SGLT2 inhibitor, metformin is mainstay in the therapy. Glycemic monitoring and target is important. GLP-1 receptor agonist is also very important. RAS blockade, non-steroidal mineralocorticoid antagonist like finerenone is also being used, and we should have a very comprehensive management in these subset of patients. Now coming to the blood pressure, which is another very important, that patients who are having blood pressure, whether having diabetes or not having diabetes, or on dialysis or not on dialysis, the goal of blood pressure is very important. And most of it is always reasonable to start the patients of diabetic with the CKD, with albuminuria or without albuminuria, with diabetes or without diabetes, should be started with the RAS inhibition, whether it is ACE inhibitor or ARB. and it should be used with the highest approved dose, and it should be gradually tailored. Once patient is on these drugs, the change in BP, the serum creatinine, and the serum potassium should be monitored very regularly, ideally at the interval of 2 to 4 weeks in the initial period of the therapy. And hyperkalemia is one aspect which is also very important. One should be very careful because many times we may need to decrease the dose or stop this drug altogether. So that modification is also very important. If somebody is having rise in the serum creatinine, then what we should do? If the serum creatinine rise is more than 30% within 4 weeks following the initiation of the treatment, then one should stop the use of this drug, because these patients are basically a subset of patients in whom GFR is very much dependent on angiotensin 2. So once we are going to block it, there is rapid rise in the serum creatinine, and probably to maintain the GFR, we have to stop the use of this drug. Patients who are having hypotension and uncontrolled hyperkalemia, when temporarily discontinue it and again restart after modifying the diet and everything. Mineralocorticoid receptor antagonists like spironolactone, phenanon are also very important, because these subset of drug can decrease the overall fibrosis in the kidney. So this is one of the main pillar being used nowadays in the clinical practice. So the KDIGO, they have given their recommendation that if you are able to control the blood pressure using the standardized office BP measurement, on using ACE and ARB for adult for having albuminuria and BP more than 120 or so, you can get a good result over the period, whether this is being recommended by KDIGO, ACCHA, or KDIGO in 2012 also. So these subset of patients should be put on these group of the medicines, and we can get a good outcome over the period. What are the evidences? We all know that there are various evidences available with us. Even if you see the very old studies like this renal study, which was conducted in 2001, they also showed that decrease in the incidence patients on losartan versus the placebo, as well as this IDNT trial, another very landmark trial, which have shown that reduction of overall primary composite and benefit in the form of doubling of creatinine, dialysis, or death. So ARB or ACE inhibitor, they have shown a promising result in previous studies even. Now, another very important aspect in the management of CKD is basically management of anemia. Anemia is very common in CKD population, and to define the anemia, one should be aware that when we will call it, the patient is having anemia. So the measurement of hemoglobin should be done annually in CKD stage 3, twice in a year for a CKD stage 4, 5 non-dialysis, and every 3 months for patients who are on dialysis or peritoneal dialysis. And patients who are not being treated with erythropoietin stimulating agent, the hemoglobin should be measured every 3 months from 3 to 5 stage, and at least monthly in patients who are on hemodialysis. To make a diagnosis of anemia, if the patient's hemoglobin is less than 13 for male or less than 12 for female, they are being called anemic. For children, if it is less than 11, for age group 0.5 to 5, and 5 to 12 if it is less than 11.5, and more than around 12 to 15 if it is less than 12. So what are the usual investigation in anemia? The CBC, the RBC, the WBC, differential counts, and platelet counts. Absolute reticulocyte count is very important. Iron profile is very important in the form of transferrin saturation, serum ferritin level, B12 and folate level. So these are the usual investigation that are being done for the workup of the anemia. There are many correctable causes which can be corrected very easily in the patients of CKD, like iron deficiency, B12 deficiency, hypothyroidism. Many patients on ACE and ARB can also have anemia also, and non-adherence to the drug also are very important. Potentially correctable, there are few causes which are potentially correctable, but there are few causes which are not possible to correct, like somebody having hemoglobinopathy or bone marrow disorders are there also. So these are the practical approach in the presence of if the patient is on ES and not showing the response. These are the list of things. One should be very careful if the patient is not showing response, even with the ESA in the CKD population. We can investigate patient for all these things. So the summary target for the management of anemia by KDIGO guideline, because KDIGO guideline came in 2012, that the target of hemoglobin should be that the patient should be on ESA if the pre-dialysis hemoglobin less than 10. So we should try to achieve a hemoglobin more than 10, but one should not go beyond 11.5 gram. Because if we are crossing the 11.5 gram of the hemoglobin, the chance of other complication, vascular complication, cardiovascular event, even the cerebrovascular event is always very high. So the target of hemoglobin should be less than 11.5 gram. Now, another very important aspect is basically CKD related mineral bone disease, because this is another very important complication with the CKD, because we all know that the most active vitamin D is being synthesized by kidney. So 125 hydroxylation means basically one hydroxylation being done by the kidney. So as there is decrease in the synthesis of calcitriol and decrease in the phosphorus excretion from the kidney, the gut, the parathyroid gland, the bone, they always try to maintain the value of all these value like calcium and phosphorus, vitamin D. So as there is decrease in the phosphate excretion and calcitriol synthesis, it's basically a complex phenomena is going on, and there are few negative feedback mechanisms happening, few positive feedback mechanisms happening, and they all try to maintain the serum phosphate, serum calcium close to the normal. So all the patients of the stage 3 and below should be investigated for CKD. So this is the recommendation from KDIGO that all patients in stage 3A and below should be investigated for with calcium, serum phosphorus, parathyroid hormone, alkaline phosphatase, and of course, vitamin D 23. So, and it should be monitored frequently, because by doing a frequent monitoring at a regular interval, we can catch the patient at the early stage. So monitoring interval, like if the patient is stage 3 and B, it should be done at 6 to 12 months duration. For stage 4, it should be 3 to 6 months. For stage 5, it should be 1 to 3 months. And patients on dialysis, the alkaline phosphatase activity should be monitored every 12 months. So patients who are having a biochemical abnormality should be measured more frequently, because then you can catch the patient early, and then you can modify the therapy like supplementation of calcium, phosphate binder, use of active vitamin D, suppression of PTH if it is needed or so. So this we can do it at a regular interval. Another very important aspect is this maintenance of calcium and phosphorus level, because this calcium phosphorus product that should not go beyond 55. So we're going to multiply the value of calcium and phosphorus. It should not go beyond the 55, because if it's happening so, the chances to have the vascular calcification and even then extravascular calcification is also very high. So the incidence of calciphylaxis or even the calcification in the coronary arteries very high if the patient is having a very high product of calcium and phosphorus. To making a diagnosis of CKD MBD in the bone, the patient should be investigated by doing a bone mineral density to assess the fracture risk in some of the patients who are having the serum abnormalities. So a dual energy X-ray abnormality like DEXA is one of the very important investigation which we can suggest in our patients. So it's also always reasonable to perform a bone biopsy in certain set of patients in which we are suspecting a renal osteodystrophy, because if you see the renal osteodystrophy, the patient may have a low turnover bone disease, a high turnover bone disease, or a mixed type of bone disease also. And to manage all these things, you can use the phosphate binder, we can use the bisphosphonates, we can supplement the uh, calcitriol for all these subset of patients. So now coming to the another aspect of CKD that's also very important, because cardiovascular disease is having very close relation with the CKD. So as I told earlier also that the incidence of cardiovascular disease is also always very high, because if you see the hazard ratio to have a coronary artery disease around 2.5 to 3 times higher than the normal population in the CKD population. So that's always very important to have very close watch on the cardiovascular disease. And to reduce this one, we have to be very close monitoring on the blood pressure, use of ACE inhibitor, SGLT2 inhibitor, and even the finerenol are supposed to be very useful. For using a different medication in the patient safety, for prescribing any medication, the calculation of GFR is very important. We should give a very precise dosing in each and every patient if the patient is of CKD. So calculation of eGFR prior to prescribing any medication is important. Use of certain nephrotoxic drug, we have to be very careful. Herbal medicines should be avoided. Metformin dose modifications should be done. And therapy for even the cancer patient, when the dose modification is required, should be done. When to patient should be referred to a specialist or a nephrologist. The subset of patients of CKD, if they are having very rapid fall in GFR, if the GFR less than 30 or so, if the patient is having massive proteinuria, if progression of CKD is a little fast, if the urine sediment is active, or hypertension is refractory, or persistent abnormality in serum potassium, recurrent stone, hereditary kidney disease, should be referred to the nephrologist. Or patient is being planned for renal replacement therapy. So again, the same picture, but here I'm trying to show you that which subset of patients should be referred. So most of the red group patients should be referred to the nephrologist for the aggressive management of CKD. Once the patient's disease progress, we have to prepare the patient for the future, and we have to prepare the patient for the initiation of RRT also if the patient stages in a stage 4, late stage 4 or stage 5 or so. So, dear friends, my take-home message would be CKD is a silent killer and we need to uncover it. CKD's progress is preventable if you are going to treat the patients in in comprehensive way. DM is the most common cause of ESRD in all across the world, and the CKD more likely CV death than the progression to ESRD. So that point we have to keep in our mind. Multi-risk factor intervention is critical, and HBC goal should be achieved. Lowering blood pressure with RAS blockade is very important. Prevent cardiovascular morbidity and mortality, and timely referral reduce mortality, reduce cost, and improves planning for RRT. And with this, thanks a lot for your patient listening, and I'm happy to answer any of your queries. Thank you.
Thank you, Dr. Sinha, for your wonderful presentation on CKD. I think across the globe, whether is it all countries, first world, developing, or whatever countries, I think this continues to be a huge problem, especially with the onset of the huge avalanche of chronic disease. So very, very timely to listen to this lesson, and in particular, the role of SGLT2 inhibitors, which have proven to be quite a miraculous drug, simple in its simplicity, but simple is action, simplicity is action, but quite amazing results and outcomes. So good to hear about these SGLT2 inhibitors. Any questions from the floor?
I would like to invite Dr. Brahm Vasudev. He's also, I think, the similar field. He's a nephrologist from US. I would like to have his inputs if joining in for in this meeting, I think the second time. So Dr. Vasudev, would you like to give your inputs over here?
Hi, thank you. It was a wonderful presentation, and in a short amount of time, I think a very vast topic got covered, from chronic kidney disease to anemia management, to management of mineral bone disease, to the newer drugs like SGL2 and GLP. So certainly, nephrology has been a very blessed field, I would say, in the last 1 or 2 years because of the advent of these newer drugs. There was a paper that came out of Rush Presbyterian Hospital in Chicago. It was by a doctor by the name of Dr. Lewis. That paper came out in NEJM in 1993, and it talked about how ACE inhibitors could change the trajectory of chronic kidney disease by reducing proteinuria. And now, after almost I would say 30 years, that this new class of drugs that you talked about, the SGL2s and the GLP-1s that have come about, and multiple studies. It's just not one study, but I think multiple multi-central trials have shown that these drugs are really beneficial. And one of the things that we have seen is, since these drugs, especially the SGL2s, cause glycosuria, we have seen cases of people getting really bad infections, UTIs, fungal infection, Fournier's gangrene, and all that stuff. So what we tell people when we put them on very clearly is that if they ever have any signs and symptoms of infection, they should stop the medicine right away, contact us, and get started on antibiotics after appropriate culture. So I think that's the only precaution we recommend with these drugs. And then the other thing is that we have to be very cautious, because these drugs also cause natriuresis. So if they're on diuretic plus an SGL2, you have to worry if they get dehydrated and stuff like that. But otherwise, a wonderful class of drugs, and hopefully, there'll be good outcome data. One of the very good things now is that anytime FDA approves a medication, they will make sure that the company provides follow-up data in 1 year or 2 years. So now you have data that comes in from millions of people, which tells that in a larger scheme of things, the drug working or not. So thank you for the wonderful presentation.
Thank you. So as I told you very clearly, that incidence of UTI in the patients on SGLT2 is severity is one very important thing. And I think maintaining the perennial hygiene is very important in these subset of patients. So we have to explain these aspects to the patient that once you are on SGLT2 inhibitor, we have to be very careful in maintaining the hygiene of your perineal region, because the incidence is not very high, but once the UTI is there, the severity is always very high. So one should be very cautious, and one should inform the physician immediately after having any sign and symptom pertaining to UTI in the perineum. Also.
Dr. Kuzi, do you have a question?
Yeah, actually, I have a more a remark. Thank you so much. It was very, very great presentation. So, what we have seen, what I have experienced, especially with my CKD patients, is that NSAIDs plays a huge role over the counter tablets that they use. That's the one thing. So there's not enough emphasis placed, when you try to tell patients what to use. I think we should be more aware of all these NSAIDs. The second thing is the role of your sulfonylureas as well as your metformin when they progress into CKD, and that one needs to stop that at one stage. And sulfonylureas actually should not be given once you are going under a GFR of 60. And what we have also experienced is the lack of knowledge under the physicians and the orthopedic surgeons regarding the GFRs. And, we are telling the patients, don't take this. And we, especially around the NSAIDs. And when we refer them for backache, because that age group normally suffers with backache or arthritis or all of those diseases, they then put them back onto an NSAID, and we're sitting with the problems with the CKD. And in South Africa, there is not a lot of specialists treating. So you as a GP need to treat these patients. And we, some of these specialists only will take a patient if the GFR is around 10. So, there's a lot of, I think, teaching that we need to, and educating of our doctors out there. Thank you so much.
Thank you. Definitely, the dose modification of metformin is always very important. One should not initiate metformin if eGFR is less than 30 or so. And reduction of dose, it was the patient is eGFR is less than 45, because the chance of lactic acidosis is always with the being connected with the metformin. But the real incidence is really very difficult to find out, because you may get patients who are taking metformin for years together, even having the low GFR, but no sign of lactic acidosis. So definitely, it's a very, very important topic. One should discuss on this. But in the real incidence of lactic acidosis with the metformin use, it's very difficult to answer this question.
And what's interesting, Dr. Sinha, is that SGLT2 inhibitors now are also used in non-diabetic patients. Yes, or true. For CV protection.
No. If you see the DAPA CKD and EMPA kidney, they have shown very clearly that even the large number of patients are non-diabetic patients. They have shown the promising result. That's why I show one of the slide pertaining to IgA nephropathy, because IgA nephropathy is the commonest form of glomerulonephritis all across the world, and there also they have shown a very good outcome. So it should be used. When to start, that's very important, because if you see the DAPA CKD, they have taken the patients up to the GFR of 24 or so. EMPA kidney, they have taken the patient up the GFR of 20 or so. But you can continue the drug even if the patient is going up to the stage of dialysis. So that can be used.
Amazing drug in its simplicity, but what good outcomes. One more thing I want to ask Dr. Sinha is the role of calcitriol. There's a lot of emphasis in the last few years on vitamin D, a lot of measurement of vitamin D, supplements with D3. I personally like calcitriol a lot. I prescribe a lot for my osteopenia patients in particular. And your experience with calcitriol in CKD?
Yes, I think that you have raised very important, valid point. I think overuse of calcitriol should be avoided, because see, the patients of CKD, and bone disease. You can have a combination of this rhinosterodystrophy. Patient may have adynamic bone disease. So once the patient is on calcitriol, there may be oversuppression of PTH also, and then that can lead to adynamic bone disease. So incidence of then spontaneous fracture and pathological fracture is always very high. So one should be very judicious in using the calcitriol. Once you are having a very clear evidence that patient is having hyperparathyroidism and PTH is higher side, and even in the CKD patients, the target PTH is around 2 times or 2.5 times to the upper limit of the PTH value. So that is, I'm talking about intact PTH. So that level should be maintained. If the patient's PTH is going below that level, then the chance of pathological fracture is always very high. The patient may develop adynamic bone disease. So calcitriol is a very good drug, but one should use it very judiciously.
Thank you. Any other questions from the floor for Dr. Sinha?
Thank you, everyone.
If not, then we'll call it a day. And as usual, what a great session and what a great presentation by Dr. Sinha. And always a timely topic. CKD, such a huge problem in all countries. You know.
Definitely.
Yeah. So thank you very much, Dr. Sinha. Most wonderful
Thank you, everyone.
presentation and
Thank
nice
you.
discussion. Nice discussion
Have
as
a
well.
great day. Thank you.
Thank you.
Namaskar.
Thank you so much.